I'm also the co-director of the Mixed Methods program and the co-director of the Anti-Racism and Health Equity program. And I'm going to pass it over to my wonderful colleague and friend, Paul Chandanabhumma.
Thank you, Justine, and good morning, everyone. In my Pacific time zone, I am Paul. I am in the Department of Family Medicine. I do human engaged, anti-racist, mixed methods, health equity research. Now increasingly pivoting towards climate change and building community resilience for that. And as Justine mentioned, I co-lead the anti-racism and health equity program with Justine, and we're really excited to um, give this presentation to you. I will start with the presentation and then turn it over to Justine, but we also want to leave some time for any discussion, feedback, inspirations from you at the end. So just to start off, we want to sort of start with some acknowledgement that we approach this, I think, with the value, most importantly, of humility, that we are anti-racism and health equity practitioners. We are by no means senior experts in this area. We continue to learn and grow from our experiences and sort of the insights that we learn from the field. So we want to share our gratitude to the work of past and present BIPOC scholars, thinkers, activists, artists, healers. We also want to acknowledge the support of Department of Family Medicine, particularly for the building block grants and building our ARAP program. We have been fortunate to receive funding for our research from the University of Michigan OVPR Anti-Racism Grant, National Center of Institutional Diversity, for our academic community partnership, and MICHAR through the State Building Capacity Grant, and recently Clinical and Translational Science Pilot Award. We do sort of want to genuinely share some common concerns that we might hear, or sometimes we discuss and then had to navigate through our journey starting all the way back in 2020. Such concerns might be captured as something like, I don't have the training to do this. I don't see how it applies to my work. I worry I will offend or hurt someone. It's too risky. I am not a minority. I'm not really the right person for this kind of work. We hear we understand these concerns, and through our talk we hope to try to convince you that anti-racism and health equity principles can be applied to any research or practitioner, to any topic, and to any project. So hopefully by the end of the presentation, hopefully will help alleviate one of those concerns earlier. And it's important to, again, just learn, and at least for us to learn and grow and start small and be intentional about the process. I think you'll hear these themes throughout our talk. Some sort of guidelines to set our discussion. We acknowledge that discussions about race and racism extend beyond professional boundaries and deeply affect our identities, our life experiences, and that we're all learning. We will make mistakes, and we will sort of learn from our mistakes or lessons learned to sort of make next right step. We try to always be patient and empathetic with each other. We want to understand rather than sort of debate or contest somebody's lived experience. And we do encourage you to step away at any point in this presentation for self-care if needed. So I will start off for today's presentation with some definitions of related to health equity, even the concept of equity, what we think of when we think about racism, and what does it mean to be engaging in anti-racist praxis, and how to incorporate intersectionality. Justine will then sort of do a deeper dive into conceptualizing and measuring race in health research and talk about two case examples of applications in digital health. We also want to acknowledge that there are debates about race and ethnicity. You may have heard that OMB is actually combining Hispanic ethnicity with questions about race. This could be a semester-long discussion, but we'll be happy to take questions if you have it at the end of today's presentation. So many of you have seen this image when we think about what is the difference between inequality, equity, and justice. In case you have not, Justine and I really like this metaphor of, I believe it's an apple tree that leans one way. So where many of us are used to the concept of inequality, which is captured here where the child on the left is getting more apples because it's leaning their way. But perhaps as sort of a base intuitive concept, sort of a first thought is, do we try to achieve equality, giving each person the same tools? So if you give both of them the ladders, and you can think of it in terms of giving everyone the same tablet, the same app, is that necessarily the solution to inequity, the unequal access to resources and opportunities? Or is it about the concept of equity, where you give people customized or tools that meet that really address inequality? So giving because the apple tree is leaning one way, you give somebody the child on the right the taller ladder so that they can reach the apple, grab the same app or same the apple from the same tree. Or are we trying to achieve justice where we don't only give sort of tailored ladders of different size, but we provide other supports to actually right that tree? So this is something for us to think about as what is sort of our value and our goals as we try to achieve health equity. We also want to sort of go over, and these are some definitions. There is no single uniform definition of these. There's been many articles that try to that debate these definitions, but we'll sort of incorporate so we can tell you how we think about these terms. So first, many of you hear about health disparities. And when we think about health disparities, we really refer to differences in health status experienced between groups. It's often sort of described as one group experiencing poorer outcomes than another group. So this we think of this as sort of a descriptive when you look at sort of differences in A1C, that one group is experiencing worse outcomes than the other. This is to contrast with the concept of health inequities, where we talk more about health disparities that experiences by one group that is related to unjust access to resources and opportunities. So here we really think more about attributing those differences to something that's unjust or unfair about sort of access to resources and opportunities. And what many of us try to vision or ascribe to is the state of health equity, which is the state in which everyone has the right resources and opportunities to achieve the highest level of health. We can discuss for 3 hours about health disparities versus health inequities. I think the importance here is to understand or define the term that you like to use, and sort of think about how you conceptualize it in your study. Another sort of complex term, but we do our best to synthesize is systemic racism. Here we took the definitions from the CDC, but actually modified it so the parts in bold to emphasize the concepts or the phenomenon that we think is important. So I'm just gonna read it. When we think about systemic racism, it's an organized and deeply rooted social system that devalues and disempowers Black, Brown, and Indigenous people and groups regarded as inferior to white people and groups, which limits access to resources and opportunities like employment, education, healthcare, increases exposure to environmental, economic, social, and health risk factors and harm, and creates and sustains racial inequities across all domains of life, including health. So what we sort of take as important and actually important enough to modify is actually to position this system of devaluing and disempowerment in relation to whiteness and Black, Brown, Indigenous people. That way capture all sort of facets of life, of livelihood, and that these systems then reinforce itself. Right? So they actually further perpetuate the systems of inequities through the ways that it impacts it in a sort of almost circular way. There are many ways to conceptualize systemic racism. Here we take the work of Owlett from a BIPOC scholar from University of Pennsylvania. They actually talk about and this is one way of conceptualizing racism. There may be other models or images that you might come across. But what we like about this system is to put systemic racism at the top as this overarching umbrella that encompasses all forms of racism. And it really separates out the individual sort of internalized racism, interpersonal racism that we think about, and sort of this cascades of structural, institutional, state, community to racism within organizations. What may be sort of a challenge here and something that we will try to solve or transform is that most of the health science education training, research funding overwhelmingly focus on implicit bias, behavioral support interventions, or insurance healthcare payments to address sort of individual level racism. And we would really like to see, we would challenge the research in the field to devote more efforts into structural racism. So what are the actual underlying factors that will ultimately improve health outcomes and health equity? If there is one, I think there's actually a couple more, but one of the first readings we'd like to recommend for you is this paper in Lancet from authored by Zinzi Bailey and Mary Bassett and colleagues. Dr. Bailey and Bassett are BIPOC scholars, and they talk about the ways they help to define structural racism and talk about the mechanisms that sort of create and perpetuate and reinforce health inequities using sort of the accumulation of evidence. And here they conceptualize structural racism as a total of ways in which society foster racial and discrimination through reinforcing systems of housing, education, employment to criminal justice, and these patterns and practices then reinforce discriminatory beliefs, values, and distribution of resources. So what I take from this definition is that it's almost like structural racism is the web that impacts all sort of facets of life from, how you seek to get a house to sort of how you seek healthcare, and that these sort of underlying patterns and practices, sometimes not apparent to us, sometimes more implicit, then reinforce the system of racial discrimination. There are many bodies of peer-reviewed literature, funders' guidance, um, the media articles, and so forth that really um, uh, encapsulate how structural racism is a fundamental cause of health inequities. And that's something that we really need to address. So if structural racism is the root cause of health inequities, then by logic, anti-racism should be the antidote or the solution to addressing health inequities. That is sort of the argument that we believe in, that the AREP really pursues. And this is encapsulated here by Dr. Rachel Hardiman, founding director of Center for Anti-Racism Research, Health Equity at University of Minnesota, talking about anti-racist research or anti-racism as a revolutionary or transformative way of doing research, that's really grounded in the notion that racism is a fundamental cause of health inequities. We do sort of acknowledge that anti-racism is within a continuum between from diversity, equity, inclusion, and anti-racism. The point we want to convey here is that all of these efforts are helpful, beneficial, and necessary. But to achieve the state, sort of the goals of anti-racism, we need to move beyond diversifying our fields or creating inclusive environment and really work actively to change the policies and the structures that perpetuate racism. One more concept, and Justine will talk about more how this sort of takes its shape in a case study, is the concept of intersectionality that was brought into prominence by Dr. Crenshaw, who defined it as a framework to understand how multiple overlapping social and political identities can magnify discrimination or privilege. That, for example, you're not, well, I can take sort of in my own positionality that I am not just an Asian American. I am also an LGBT identified individual, and I am an intersection of those and multiple other identities. And it can be sort of conceptualized as an example of a traffic intersection, thinking about how the harm in terms of health inequity is being experienced here. So if you imagine a Black woman at a traffic circle with traffic coming in here possibly four directions. Sometimes they come in one direction, sometimes they come in both. But if the Black woman is harmed in any way, it is because her injury, and you can think about it in terms of health outcomes, could result from sex or gender discrimination, race discrimination, or both. So important to think about how that might take shape in your own study or your own area of research. So when we talk about anti-racist praxis, today we will focus about how to treat race as a social construct and not a biological one. But other sort of principles that are important to us to ARAP includes focusing on experience of racialized communities and people as concepts of centering the margins, or sort of moving the margin to the center, applying intersectionality, the concept that I just mentioned throughout the process, and that racism isn't just about individual level factors or behavior or interpersonal action, but as important to highlight structural, institutional, and programmatic levels. And that even includes like how we do science. So how is funding decision making being made? Are the teams that are truly diverse and inclusive? And finally, incorporate strength-based models, moving away from treating communities as deficits to fulfill or to fix, to really acknowledge, honor the protective factors that promote wellness. So think about factors related to community individual resilience, social support and connections, and identity pride. We'll now turn over to Justine.
Thank you,
Uh,
Paul. I think we'll just take a second to ask if there's any clarifications about those definitions. And if there's none, I'll just move on.
I have a quick question. So you mentioned these mutually reinforcing systems. Do you have an example of that? Or
Sure. So, for example, the example, if you go back to the intersectionality picture, Paul. So, one person is not just subject to one system of discrimination, it might be multiple. So, the system of discrimination against sex or gender, and the system of discrimination based upon race, ethnicity, the system of discrimination based upon the language you speak, the system of discrimination based upon having lower income. So that they're mutually reinforcing and perhaps magnify the power and or lack of power you have to access to resources and ultimately to better health.
yeah, I have a concrete example. I have a close colleague who works in the area of immigration and intersectional racism. So consider an example of a person who is stopped at a traffic circle and cited a ticket and then reported to immigration ICE for possible sort of undocumented status. So is that person being stopped based on their, how the enforcement perceives their race, and then sort of this sort of immigration or xenophobia, and in terms of being referred to down the road. And you can see sort of, you can imagine down the road sort of criminal justice system, detention centers, and so forth, and how they reinforce and sort of serve to create sort of differences and discrimination and inequities.
I'll give one other example from my own life because I think it's really concrete. While my family identify as Asian American immigrants, we have mutually reinforcing systems of power as well. So we are at this point in our lives, a higher income family, 2 doctors in the family. And so my son, when he applied to colleges last year, had these really powers of privilege intersecting such that, he was a decent school student, not an amazing student, but because we could pay for all his college applications, he paid for the higher chance to get into good college. We didn't have to do any financial aid. So it can be mutually reinforcing for power and privilege as well, too. Is that helpful?
yeah, thank you.
Yep. Okay. So I'm going to go on to again, if you don't read many, you only take away 2 articles. I think the one we mentioned, but this one is such a fast read, and I refer to it all the time. It's available publicly in Health Affairs, came out in 2020, and it's a standard, almost a checklist for reporting on racial health inequities and how to treat race. Next slide. And then the other one that I draw upon a lot is this one by L. Lett, again, a sort of a brilliant statistician and thought leader at UPenn, this conceptualizing, contextualizing, operationalizing race and quantitative health sciences research really breaks down some concrete examples of how to measure, treat race, and talk about it in your studies and contextualize it. Next slide. So just breaking it down before you even start your study design, what Dr. Boyd and Dr. Lett and their colleagues encourage is to just think about, why do we even need to measure race for this study? We do it reflexively, but why? What's the rationale? How will we measure it? How will we analyze it? And what are the limitations of the measures we chose and the analysis we can do with the data we have? Is there any way to mitigate these limitations ahead of time? And if we can't, how are we going to talk about it in our conclusions and our dissemination? Next slide. So recognizing that race is an imperfect measure because it's a social construct, not a genetic one, there are ways to mitigate the limitations of this measure. One is you can include measures of exposure to different levels of systemic racism. And I just list a couple here. There are scales that are validated to assess interpersonal racism experienced every day in daily life with the Everyday Discrimination Scale, the EDS, that was developed by Nancy Krieger and her colleagues. There are multiple indices of structural racism at the neighborhood level, state level, such as the Social Vulnerability Index. And I'm going to give you a concrete example of a state level measure of structural racism. And even with just the data you have, you can think about intersecting identities that would mutually reinforce positions of power or lack of power. So for example, you can perhaps do a sub-analysis of those who identify as Black, transgender, and are young, and compare them across groups to look at associations with outcomes. And finally, go back, Paul. Just to be very careful that you don't attribute one racial group's findings to the entire group, that there may be differences that you're not measuring for. So you can ask questions about group identities, such as the country of origin, your cultural identity, or your native language. A classic example of problems when we fail to do this is the model minority myth, which is a common misperception that Asians are successful, smart, and that other minorities, if they just worked hard enough, would be able to succeed and overcome hardship. And the problem with this extrapolation of data of one Asian group to all the others is it obscures economic disparities among some Asians versus others. So I could use myself as an example again. While our families are both immigrant families, we weren't high income per se, but my father was an engineer who was recruited from Taiwan in the 70s to come work at IBM. My father-in-law was recruited. He was a PhD candidate from India, so high level of education. And this swath of immigrants who came over in the 70s, 80s from Taiwan, India, then became held up as the standard for all Asians and obscures the severe disparities experienced by those from, say, Cambodia, Vietnam, and those lower income and who did not have high educational degrees. Another way to overcome limitations of race is to use all these public databases that are available if you can't easily collect that data among your own participants. Some examples is the US Census, the CDC BREFIS, or the Behavioral Risk Factor Surveillance, and NHANES, or the National Health and Nutritional Examination Survey, for example, looking at state-level food insecurity as a proxy for racism and other systemic barriers to discrimination. When reporting race and its associations with the outcome, it's very tempting to collapse all of these really small categories into other. As much as we can, disaggregating race will allow you to see differences that may be specific to one group and not another. And if you can't do that for whatever reason, let's say the groups are so small that you risk exposure of anonymity or identifiers, then at least acknowledge it in your discussion and consider what are some unmeasured mediators of race, implications for your findings in future research. So we're not advocating that people need to take on the system of racism in all of their papers, but to just consider what they were not able to address and talk about it and raise it as a need or a gap for future research and funding priorities. So here's a really great example of using these public databases to look at something that we've been thinking about for years is why aren't we having more people get COVID vaccination? And a lot of focus has been on individual level vaccine hesitancy. So this group, Siegel and all, they basically created this and validated the State Structural Racism Index using 3 databases: the US Census, the American Community Survey, the Bureau of Justice Statistics. And they looked at 5 dimensions of life that we know have been historically and currently affected by systems of racism: segregation, incarceration, education, economic, livelihood, and employment. So what we found was this, and the way to read this chart is across the x-axis is the state structural racism index from 0 to 100, 100 being the highest level of evidence of structural racism and 0 being the lowest. And along the y-axis is the disparity between Black vaccination rate and white vaccination rates. Anything above the line of 0 implies that Black vaccination rate is doing better than white vaccination rate. 0 would be they're the same. And anything under that line indicates a disparity such that Black vaccination rate is lower than white. And you can see almost all of the states fall under this line. If you go ahead, Paul. One more click. Okay, so the final interpretation is among the 45 states that they were able to get data from, for each standard deviation increase along this x-axis in the index, Black vaccination rates will drop by 3.15 percentage points compared to white vaccination rates. Now, they adjusted for vaccine hesitancy and 2020 presidential voting patterns, which were felt to be a proxy for vaccine hesitancy, and the findings remained significant, such that Blacks had a 2.87% lower percentage rate of vaccination for every increase in standard deviation of this index. And just sort of out of curiosity, if you go ahead, Paul, with the next one, let's look at the range, which is Alaska. Actually, the Black vaccination rate was slightly higher. On the other end, we have Wisconsin, where there was a significant disparity there of 18, almost 19 percentage point difference. And then Michigan, we kind of fall in the middle, where we have an 11% difference between Black-white vaccine rate. And so what I took away from the study is, wow, we do a lot of work as a doctor, I spent a lot of time talking about vaccine hesitancy. And we spend campaigns doing it, but perhaps, the resources may be better funneled to access. And one thing of note in Alaska, which did the best, is they directed their vaccine sites to the areas that had the highest area of deprivation. Now, I want to give some practical guidance for how to measure race by self-report, because we all do this in almost all of our studies. And so some best practices are to include Middle Eastern and North Africans separately from white. Their ancestry, immigration patterns, migration patterns are distinctly different from white European. And particularly being in Michigan with such a high number of Middle Eastern population, that we really need to be doing this better in Michigan. Separate Asian from Native Hawaiians and Pacific Islanders. Include multiracial category. Multiracial is preferred over the word mixed. Prefer to describe should be a category as well too, to get some of those differences in a self-identity with respect to country of origin or tribal affiliation. Avoiding the term other, I think for obvious reasons. And then consider the order in which groups are listed and avoid defaulting to white first without a reason. And more journals are expecting you to report how and why you decided to report race as well as ethnicity. Go ahead, Paul. So just to point out, JAMA updated their guidance on reporting on race and ethnicity in 2020. And we now provide, this is our example. It's just one way. It's not perfect, but it's just one example of asking about race, giving people the option of picking more than one, and having an option that includes and prompts people to include tribal affiliation, country of origin, or anything else that they would like us to know about their racial identity. Oh, just to note here, that was listed. I chose in this one to list in alphabetical order. There may be reasons that you choose to do it differently, and I would just justify it, think about it and justify it.
Really quick question. Would you guys be willing to share these slides out afterwards?
Yes, Emma.
Okay, wonderful. Thank you.
You're welcome.
Sorry to interrupt.
No worries. So that's an easy question. So the case studies, I have 2 case studies and then we'll wrap up. Because this is a digital health group, I wanted to talk about wearable tech. I am not a digital tech, wearable tech expert, so if anybody knows more out there, please chime in. But this is a nice commentary by Dr. Merritt and Volpe about using these wearable technologies, Fitbit or Apple Watch, to detect atrial fibrillation. So another recommended reading. Okay, so this is the innovation. This is what people are excited about, is that to detect atrial fibrillation, and for people who are not clinicians or not familiar, atrial fibrillation is an irregular heart rate that can then predispose to blood stasis, so it's not moving well, and the clot forms, and the clot can then break up and cause a stroke, which is devastating as far as burden and quality of life. So to detect atrial fibrillation, a clinician orders a monitor that you have to wear at home for days to weeks. Sometimes the monitors are a little clunky. You put them on your belt, and now there's these new monitors that are just a little patch you put on your skin, but they're expensive and it requires a clinician to order it. So the idea is that these Apple Watches and Fitbits can now detect irregular heartbeats. And so that's the exciting innovation. And the assumption would be that wearable technology is going to improve access, cost, timely and objective diagnoses of AFib, leading to earlier intervention and reducing racial health disparities in AFib, congestive heart failure that can result from atrial fibrillation and death ultimately. The problem is that the technology relies upon photoplasmographic PPG sensors that then estimate how the light is being absorbed by your skin, specifically a green light wave. And then they take these waveforms and they pass them through this algorithm to then identify and have the machine identify what looks like atrial fibrillation. And just the wonky doctor in me, I put a little tracing of what atrial fibrillation looks like at the top. And so, clinicians don't always agree with atrial fibrillation looks like, but so the idea is we feed the machine and it can get more and more accurate. The problem is that we know through studies that people with darker skin and people with larger bodies have less accurate readings. And that kind of makes sense because if you think about absorption of the light through the skin. And it's unclear which populations were included in the data that generates these algorithms because they're proprietary, owned by Fitbit and Apple. So this group here did this really interesting study where they took 3 different wearables, the Apple Watch, the Fitbit Versa 2, which is what I wear, and the Polar M600, which I've never heard of. But they did these simulations of these 3 devices and looking at different variations, skin tone and skin thickness. And what they saw is that if you just change skin tone alone, the variation across devices was about 10%. But if you considered skin tone variation and weight variation, the difference across devices could be as much as 61%, suggesting that the combined effect of weight and higher melanin concentration could contribute to the errors that have been previously reported. So keeping that in mind, let's look at this huge study. The Fitbit Heart Study was published in 2020. It was this prospective remote clinical trial, and they basically contacted about 500,000 Fitbit users and said, do you want to be in the study? And among those who enrolled, 1% had an irregular heart rate. And then they said to them, okay, now we're going to give you these EKG patches and we're going to use that as a gold standard and see how accurate the Fitbit was at detecting undiagnosed atrial fibrillation. And remember that there's this algorithm that's proprietary that they used, again, developed by Fitbit. What I find most interesting, now this is an amazing study, so I'm not knocking it. I'm just trying to point out from looking at a health inequity and racial anti-racist praxis, how do we interrogate this? So if you look at the demographics alone, among those 4,728 people who had an irregular heartbeat, those with a body mass index of 30 or more was nearly half. The vast majority of participants were white. only 4% of participants were Black. And if you look at the race and ethnicity categories here, you can see there's very few other minorities like Asian, Native American, multiracial. But I think what caught my eye is other and prefer not to say we're just squished together into one box. And they certainly are not the same. And then there's a sizable minority here, 6%, who just didn't report. And so how are they asking about race? How do you get such a high number of not reported? When I went and I looked into their protocol, I couldn't find the original survey items. So that would have been interesting to see is if we could improve upon the way race and ethnicity were asked. The final results, which were super exciting for everybody, is that this wearable's positive predictive value of detecting undiagnosed atrial fibrillation was 97% for people 65 years or older. And that's important because this is the group that most likely has undiagnosed atrial fibrillation or highest risk for stroke. However, they did not look at differences across racial groups, ethnic groups, or BMI groups, the very factors that we know are linked to inaccurate PPG readings. Now, again, we said it's fine if you have limitations on race and your ability to have inclusive, diverse groups, but talk about it in your discussion section so we can understand the generalizability of your findings. So when I went through the discussion, I found one sentence, which is, despite the relative, and these are my quotes, relative geographic and racial diversity of participants, which I don't think that there was a diverse group of participants as we just looked at, future assessment of the software algorithm in, quote, more diverse groups, including those who can't afford a wearable device, is necessary. And that was it. So if we were to imagine that we could do Fitbit Heart Study 2.0, we had lots of money to do an implementation trial. How could we apply anti-racist praxis and health equity framework to a design? These are just my ideas. If people think of others, let's talk about it. One is let's give wearables to all participants at no cost. They've done this before. Two is to get some smart engineers to correct the technology for inaccuracies across different skin tones and skin thicknesses. Three is to evaluate skin thickness as a variable, evaluate skin tone as a variable. The Fitzpatrick scale is commonly used by dermatologists. And I want to point to this emerging, exciting work from Dr. Ellis Monk, who's a Harvard researcher. He has done some groundbreaking work on the effects of colorism and outcomes. And colorism is discrimination based upon the darkness of your skin. Colorism is seen among Black patients, Black people, and among brown people, particularly, for example, in India, where light-skinned people are considered a higher rank than darker-skinned people. So what Monk has tried to do is he has teamed up with Google AI. And if you look here on the bottom right, they are creating and feeding AI to better identify skin tone variations using machine learning. And so you can check out that website. So those are all tools that are out there to evaluate skin tone. And then if we know skin tone and skin thickness are really important to the accuracy of the Fitbit, I would need a rationale for including race and ethnicity. And there may very well be one, but I just can't think of it right now. So if we were to do that study, we would have to consider why we would be asking that question. And finally is to consider other unmeasurable mediators and moderators. So for example, the Fitbit is best at detecting atrial fibrillation or irregular heart rate if you're sitting quietly for at least 30 minutes. And so I would be interested maybe in occupation. That is, people who are in knowledge jobs sit longer, right? And so what's the difference in accuracies or consistency compared to, say, people who are in manual labor jobs where it's really hard to sit down or work 12-hour shifts? And I'm going to conclude with my own case study. This is the trial that we're running right now. I developed a web-based contraceptive decision support tool. It's not a native phone app. It's a web-based tool, but it can be used on your phone. And that's how a lot of participants in the pilot study used it. And so I want to just walk through some lessons learned for me through my pilot study and then launching this R01. When I first started off with the study, I was in my K at Word and I got lots of advice. So one of my mentors said, who was really a proponent of cultural diversity, he said, you really should make a tool in Spanish at the same time. You are leaving out a whole population of people who need this care otherwise. And that was a really compelling argument. Later on, I got asked by a clinician, well, what about all the transgender patients who want birth control to control menses, but they don't actually need pregnancy prevention because they're not engaging in penile vaginal intercourse? Shouldn't they be eligible too? So, being a junior in my career, wanting to save the world, I really seriously considered doing all of this. And it came down to it. I realized I wasn't going to do all of this very well. So I just want to caution, in the rush to be more inclusive, there's a risk of delivering ineffective and potentially harmful interventions to minoritized groups. I'm going to give you an example with the transgender patients who want birth control. Those who have a uterus and want to decrease menstrual flow, there's many different ways to do it beyond birth control. It could be hysterectomy, it could be ablation of the uterus. And so my tool was not meant to provide comprehensive counseling about menstrual suppression. My tool was about birth control for pregnancy prevention. And so for me to just hand an incomplete tool over to transgender patients who wanted that information would have been a disservice, and in fact, unethical. So the thing I learned from this work is, a digital health tool, in this case, a decision support tool, is really designed for a specific reason, for a specific group, under specific circumstances, and a single tool cannot nor should do all of it. So one of the key principles of anti-racist practice is just be wary of speed and to slow down. And this work is not about getting more solutions to more people faster. It's really about getting the right solution to the right people at the right time. An example of applying intersectionality was in my tool was just to acknowledge and raise awareness of well-documented historical contemporary examples of reproductive coercion, particularly of Black, low-income young people and those with disabilities. Examples include egregious examples of forced sterilization around the turn of the 20th century, all the way up till now, where physicians have refused to remove IUDs upon request, more often of Black, low-income and young people and those with disabilities, based upon the paternalistic belief that you'd be better off if you don't get pregnant and become a parent at this time. So to kind of build in this potential harm, to mitigate against that, we included this contraceptive Bill of Rights to remind people they have a right to say no if they're not comfortable, and to give them a sense of agency. This is a quote from one of our qualitative interviews that informed the decision to use this language. It makes you feel like you have a sense of agency and you have the freedom to make the choice that's best for you and not feel pressured into anything by anyone else. I also learned that, and this is a long-standing problem that we're trying to wrestle with, is that it's engagement, recruitment, retention of minoritized participants doesn't happen overnight. A common misconception is that, well, they don't trust us because of historical wrongs, and therefore they're not interested in research. And research has showed the exact opposite, is that these communities do want to be involved in research. It's just about how. And so the anti-racist health equity approach would be, it's not about that they don't trust us, it's that we haven't earned their trust. and that we haven't made research opportunities low burden and accessible. So one way to earn trust can be in your messaging and your visuals. I did not do well with recruiting minorities in my pilot study. I'm hoping to do better in the R01. Here's some examples of some of the graphics we've developed now that I have a little bit more money. Hiring a graphic artist to provide more inclusive photos, to be very explicit that we welcome people of all gender identities, sexual orientations, race, ethnicities, cultures, and abilities. And if you kind of click through the other pictures there, I guess, people can't know something that you don't say. I had clinicians come up to me and say, "Are transgender people eligible?" And I said, "Well, I thought it was obvious, but not if I don't say it." So that's why we included that statement here. And hopefully we have better success with having a more racial ethnic minorities be engaged with the research. And we want to thank you all for your time and just turn the tables around and ask what questions you have and maybe think through some of the projects you're doing and how we may apply these principles to your project.